In this episode of Vital Conversations, a Doc Talk community series, Dr. Tamang sits down with Tim Trithart, CEO of Complete Health, to discuss pressing healthcare challenges and opportunities in the region. They explore access to care, insurance barriers, and Sanford Health's expansion into West River. The conversation also highlights the role of federally qualified health centers, the cost and quality of care, and how Monument Health can better serve the community. It's coming up on Vital Conversations.
How are you?
I'm good. How are you?
Good. I'm excited to talk to you. I think one of the main areas that I wanted to make sure we covered is access. I feel like you're probably one of the best people in the city to talk to about access to healthcare.
I'm not one of the best. I'm the best.
Yeah, I think so. Tell me your thoughts on it, the landscape we have, how we get folks care in our community, and maybe nationally too.
I think that it's, we do, Monument Health does a, community needs assessment every 3 years, and, asking in terms of what the greatest needs are in our region. And access to healthcare is huge. And so it's always in terms of how do you define that? One is in terms of, getting an appointment and how quickly I can get an appointment. And the one obviously is whether I can afford to see whoever I want to see. And it's a challenge. And I think it will continue to be a challenge. And I think healthcare is expensive across the board, and so it's expensive to provide, and it's expensive to get.
Yes.
So access, and we see it every day at our clinic.
Tell me about that specifically, how an FQHC fits in, what role that plays.
Yeah, I'll be honest in terms of, I used to work at Monument a gazillion years ago. And when I applied for the job over at then, we were called Community Health Center of the Black Hills, I knew like this much about federally qualified health centers. And really, I've been a convert over the last 14 years that it is really the way primary care should be provided.
Tell me about it.
It's because we do like an integrated model. And so we've got medical, dental, pharmaceutical, mental health, all co-located in one place. And so much of what one of the problems I think that we have of healthcare is that it gets to be so fragmented, and so we have the unique sort of position that we're all sort of integrated. And so there's so few health issues, as you well know, are exclusive to one area. And so from a federally qualified health center standpoint, we are just like any other clinic that anybody can come and see us. If you have insurance, you can come and see us. If you're rich, you can come and see us.
Yeah. I think there's this perception that, okay, that's for the low SES.
Yeah.
And I don't think that's the idea. I don't think that's what we're really aiming for with that. Speak to that.
Yeah. So, I think that, we get designated a federally qualified health center. And so everybody thinks, there has to be some sort of a way that you qualify to be, to walk in the doors, basically. And so I hear that from a lot of people. It's like, I didn't know that I could go there. I thought I had to be on Medicaid or, I had to be, uninsured or what that. No, anybody can walk through our door and see us and take advantage of all of those sort of services that we have. What makes us unique and what makes us a federally qualified health center is that we get a grant that allows us to or requires us to provide care on a sliding scale. And so we have a sliding scale. So whether you're insured or uninsured, you can apply for that sliding scale, and so that we can reduce the cost. And so that's, again, trying to make sure that access to health care is affordable.
Isn't that kind of the way it should be? I mean, I mean, if you don't have any financial strength, but we live in a society, you should be able to access on some sort of sliding scale. So it seems to me that that's kind of a no-brainer.
Yeah. One of the things that, yesterday we were interviewing for a new provider, and one of the questions that we always ask a new provider that's coming on board is whether you think health care is a right or a privilege.
Yeah.
And obviously there's no right answer necessarily for that. But for me, it's always telling in terms of when we talk about that with a provider, in terms of, how do you interpret that? Because clearly there are probably aspects of healthcare that I would go, I don't know if everybody needs to have access to that aspect of it. But I think basic primary care, is it's a right. I think here in America, we can afford to do that. And honestly, it makes sense for us to do that.
Even if you're a cold-blooded purist who says it's all about your choices, if you don't take care of those folks, it's going to cost you anyway, much worse. So like financially, even if you don't do it for the right reasons, some of those things have to be like a utility.
Yeah, well, I talk with people in terms of whether it is it's like people if it's a privilege, you can kind of push back on that and go, well, if somebody is on death's door, shouldn't we provide them with emergency care and save their lives? And everybody's like, well, yeah, of course. Yeah, if somebody's having a heart attack, you need to,
right.
do what you need to do.
Maybe Botox and fillers can be a privilege. But
yeah. So,
if that's healthcare, I don't know.
Yeah, but you could argue, am I having migraines? And the Botox is going to keep me, from having the migraines and keep me a productive member of society by going to work. Well, then maybe that aspect of it should be. So, so I think for me, it's in terms of, as a good functioning society, it's almost like education. Is that how do you keep your populace to be as healthy as they can be?
100%. And I don't want to pass over something you said that I think a lot of people don't know about. You mentioned dental.
Yeah.
You mentioned pharmacy. And then I'm interested in how accessible those services are, because professionally, I know so many patients that are in desperate need of dental care. And mental health. How does that play a role in the FQHC world, the sliding scale world, our city?
Yeah. Well, dental is, I don't know what it is right now if you went to Monument's emergency room, but traditionally it is probably within your top 5 reasons as to why uninsured people show up in
it's
the emergency
painful.
room.
Yeah.
Right. Yeah. And we do operate. It's an incredibly busy dental area.
I can
that
imagine.
It's that dental is often the entry point for a lot of other issues that you're able to identify, whether it be some high blood pressure issues or cancer issues and things like that. And so many folks that avoid going to see the doctor and taking care of some of their primary care stuff, when that tooth hurts, that's when I got to take care of this. And so they'll show up and we're able to kind of get them then integrated within our system.
And is that service still kind of on the sliding scale, the same?
Yeah,
so that's amazing.
Yeah, and so we try to keep that as affordable as possible. And so again, in terms of our sliding scale, I mean, it's income based.
Yeah.
And so we have an income scale that basically that we reduce the cost of dental care if you are at 200% or double whatever the federal poverty line is. And so if you're above that, or if you fail to provide us with the materials that, to prove that, basically, then basically you're going to pay the same out of pocket as you would if you were going to any other dental clinic or any other medical clinic. And so that we want to keep that as affordable as possible. So it's kind of a gradated, sort of. But at the very low, if you're at the federal poverty line, to get your teeth cleaned, it's $15.
Hey, that's a deal. Yeah.
Which is still a lot if you're on the federal poverty line.
Yeah.
It's
but
$50.
Accessible.
But, the idea is that it's still going to cost you something.
Yeah.
It's probably still, but it's trying to get you integrated. So when somebody comes in there with that tooth pain, it's then developing a great rapport with them to get them scheduled to come back in at an affordable rate to get their teeth cleaned.
Do you see complete care as part of a continuum of services? So in other words, do you see it as, okay, this is where we are, and then maybe down the road we have the multi-specialty clinics. That's another organization. I think the reason I'm bringing that up is because in our system, it almost seems like we're fragmented a little bit. Maybe it's necessary, maybe it's a continuum, but you look at the residency clinic, you look at Oyate Health, you look at, of course, Monument has outpatient clinics, and then you look at kind of the specialists that are outside of all of that. I don't know why they're blanking my name, but there's a couple of other clinics that provide primary care. Are you part of a spectrum, or are you trying to do the whole thing, or what's your take on kind of the city demographics of just the line of care for access to primary care and then some of the specialty stuff?
Well, I think that I think that our role at Complete Health is primary care. It's basic day-to-day, meat and potatoes care. And to be able to, take care of that and an integrated sort of thing, just kind of the entry level sort of thing. And we were, talking, I just talked about the dental thing, but, mental health is obviously a key part of, primary care from a medical perspective. I mean, you can't deal with diabetes unless you're dealing with somebody's social determinants of health, what their housing situation is, what their food situation is, what their level of depression is, and how you're dealing with that. It's really hard to get somebody to,
Yes.
get their blood sugar levels down without dealing with all those sort of things. And so we see that as, kind of that primary care. How can we take care of, some of the basics sort of thing in an all in one sort of shop? You go to the grocery store, you hit every single aisle so that you can create a whole meal. But there are still probably some specialty services that they aren't going to have when you go to, Safeway. They're going to have, it's like, I want some special meat that they don't have, or, some special services that they don't have, which we will always never have within our clinic. And we don't see that really as our role.
Yeah. And that's kind of what I'm getting at. So some of the subspecialties, those are not something that you feel the need.
No.
And I've been really, I know many of your providers, and you've got like I would say you have a mission-driven crew.
Oh,
And some of them have moved into areas that I sense they did it because it's like, we have to do this.
Yeah.
Like, I think you're treating HIV, if I understand right. You're treating hepatitis C.
Yep.
You're doing stuff with addiction that I think a lot of primary care providers would be like, this, I'm going to send this to the ID guys that have maybe quite a long wait list and some access issues.
Yeah, and I don't want to brag too much, but I do think
this is the place.
Brag.
That's why you're here.
But I always say, our providers are really great when it comes, because much like in a rural setting where you're kind of challenged because you don't have the options to refer off to a specialist at the drop of a hat, because because it's tough if you're uninsured and you don't have those options as to where you're going to go. So as you know, I'm sure my providers have talked to you a lot of times and going, hey, I've got this difficult case here. Can you give me some advice in terms of how I should handle this within a primary care setting?
Yes.
And so from my standpoint, from a small C community health sort of thing, that's a really effective, cost-effective way to, if there is something that can be handled, at one appointment, it's much better than let's make another appointment and you go someplace else to see some other specialist.
Plus, your providers have all the base knowledge and the relationship with that patient.
Exactly.
And I don't know what the statistics are, but generally speaking, if you send a patient from a primary care clinic to a subspecialist, it's very often that either the information isn't transferred appropriately, so the subspecialist doesn't exactly understand what's going on, but a lot of times, just logistically, the patient never shows up.
Yep.
And quite frequently, you're looking at delays of weeks to months to even get there.
Yeah. One of the things that, we've got an in-house pharmacy that we have within our clinic, and we're able to offer reduced price medications. You have to be a patient of ours in order to get them. So you have to be seeing one of our providers, or we have to have sent you off to a specialist, that we've got that referral, but you can get your prescriptions filled. And so our copays are generally, even if you're insured, the copays are even cheaper on that. So, but I just learned this week that we, send scripts to our pharmacist. Pharmacists fill those scripts, put them in the bag or whatever, ready for you to come pick them up. And probably they get picked up, 70% of the time. And then about 30% of the time they hang there. We try and get them to come in. They don't pick up the medications that their doctor, and then, they which to me is just a staggering sort of number.
It's disturbing.
Yeah. And so we're, I think, uniquely positioned. I don't think, and that's not unique. I think you can probably go to any pharmacist in town.
Yep.
I think, again, what that integrated model that allows us to do is to go, hey, walk
when
down
they
the
come
hall.
back,
Yeah, exactly.
Yeah.
You didn't pick up your hypertensive medicine. We talked about this, and, and it also allows us to go, why is it that they didn't pick it up? Did they not have transportation to come pick it up? Is there, something else that's going on in their life that's, more important?
Yes.
Did they get, evicted from their, their apartment? That they're, and those sort of things that, play into it. It's usually, there's a lot of complexity, I think, to people's lives. And so we try to take that into account.
Yes, that's excellent. So you have the kind of the grant component to care for the lower SES.
Yep.
Now the higher, I would say mid or higher range folks that come in.
Yep.
How's your battle with the insurance companies? How does the third-party payer system work for?
It gets harder and harder.
Yes.
Year over year. It's a challenge. I think we work in a field that obviously is incredibly complex and regulated.
Yes.
And so
I'm interested in your thought on a current, I don't know if it's a cultural controversy, but United Healthcare CEO murder Brian Thompson and Luigi Mangione.
Yep.
When I first heard that, I think like almost all of us, we were like, that's a terrible thing. And then I think a lot of us were shocked when we saw a lot of people didn't think it was a terrible thing.
Yeah.
And then it started raising all these questions about the ethics behind these third-party payers. And, traditionally I would be like, oh, they can't be that bad. But I personally have encountered terrible situations trying to get a patient something they desperately need.
Yep.
These are not fake scenarios. These are legitimate, my eyes, my patient, me trying to get a desperate medication for somebody, and they denying it for no reason.
Yep.
And then setting up a really difficult process, which you win in appeal. You win these in appeal. I've always won them in appeal,
Yeah.
which makes me think their methods are, not correct. Because if you win them all in appeal, that means their screening methods were not correct. So from someone who cares for, a full range, I'm interested in your take on that.
The problem is that healthcare is so expensive. And so, and it is so fragmented from the insurance standpoint. I mean, that we see they all have their different rules from a billing standpoint. These require that you submit these claims, this way. And, if it's secondary insurance, you have to do this. And these you got to do by hand. And these you got to do by fax. And these you have to do electronic. This is the reason that it's been, we get a lot that get denied because, there's an address that's changed. And, it's like, yeah, it's, and they'll play this game that you go back and forth, and then they'll go, oh, timely filing that you had 6 months to get this all completed. You guys didn't complete that in time, so it's a little game race sort of thing that you're trying to figure out.
Right,
and it's I think at Complete Health I've got roughly about 100 staff that work in the organization. And I've got, I think right now, 8, 9 people that are just in the billing department dealing
that's
with
terrible,
all that.
isn't that?
And
yeah.
they're all great people,
right?
Yeah, and they all do
you
an
could
amazing job.
Use those people's talents other than trying to get paid for the work you've already done.
But I just try to, any other private business that you had 100 people in there, how many people are actually in there working your accounts payable that are working that? Yeah, it's like you've got one person that's sending out, Yeah,
the case that I remember specifically that I was most angry about, there were many, but and I won't say the particular third party, but this patient had been denied treatment for hepatitis C, and they clearly met every check. I mean, even our Medicaid would have paid for it, and Medicaid had some pretty high standards back then. Flat out denial, and then I got I appealed, and then I got a discussion with their doctor who. I've lost all respect for those people, unfortunately. It was a neonatologist that I had to talk to about adult hepatitis C medication. And he was cool when I finally talked to him. He acknowledged the ridiculousness of what was happening. And then, you won't be surprised by this, he needed me to draft a certain letter to send on to another group.
Yeah.
And then he ended up supporting it. And like I said, we always got it approved. But the third-party system is... there's got to be a better way. And I think when you look at the way an FQHC is run, I really do wonder if there's a model for it's like, a sliding scale where maybe the top end even gets a little heavier, Maybe that's the idea where the bottom end is, is subsidized completely. That seems more fair to me. I don't know. Does that play out? Does that play out all the way across the line?
It's, unfortunately, I think the challenge for us is that we rely on those third-party payers, even in an organization like ours, that those that fall on our sliding scale.
So do we.
Probably about it's 25% of our patients, is what falls on our sliding scale.
Oh wow! So 75% are
have some sort of other.
Yeah.
There's a number of them that are on Medicaid.
Sure.
That probably a third of our patients are covered by Medicaid. Most of those are kids that come through. And then the other, are folks that have some sort of private insurance, whether it be a Wellmark or Humana or whatever it is. So, and so we depend on them. It's not like I can. It's part of our puzzle that we have to put together to be.
Yeah,
able to
and
pay
it's
for
a little
these.
sketchy too because your contracts with those third parties might not be the same as contracts with other.
Yep.
They. My understanding is there's different rates for different groups, and I think there was some legislation that tried to make that transparent, which some groups didn't like
It's
that
a
very
challenge,
much.
yeah.
So it gets even more murky.
Yeah.
I don't know. You're a smart guy. Is there any systems that you see, and it's going to be really interesting to see what this administration does with healthcare. I don't think it's been laid out clearly yet.
Still pretty nebulous.
Yes. I think we're all kind of wondering.
Kind of waiting.
Yeah.
Yes. I had staff yesterday says, can you send out something to all staff and tell us what we should be expecting? And I'm going, well, boy, you give me a lot of credit if you think I
have a line to that.
So.
What do you think is the future here in the next few years? Regulation, payers, where would you like to see it go? I'll tell you how we get paid as a federally qualified health center through Medicaid. I think is a really great model from a primary care standpoint because unlike that's one of the unique things that we have is we get paid basically a flat rate. They say, here's for every visit that comes through your doors, we're going to give you X amount of dollars, and that just makes sense to me. Yeah. You just do what you need to do, the idea would be that, it's like, okay, some are going to be more expensive, some will be less expensive, but this is kind of, in order for you to be able to continue open your doors. And I wish healthcare could get more along that. We spend, I don't know how many gazillions of dollars that we spend. That's about right, one gazillion. Something like that. Yeah. And the amount of money that actually goes through, we spend, I think it's roughly $13,000 per capita that we spend on every American on healthcare every year. And only roughly about $600 of that is on primary care. Yeah, and allegedly our outcomes aren't super awesome. Right. Yeah. And so that for me is just, I always go, if you gave me, as an administrator, if you gave me $13,000 for every person in Rapid City, and you guys at Monument had to come to me to get paid for what you guys do, rather than go, it's like, that would be a really interesting model. I think that, that you paid primary care and primary care had to figure out how they're doing it. It's such a pickle. I'm interested in your thoughts on some of the groups, I should say, that have tried to disrupt this already. Like it seems like every major pharmacy has tried to disrupt primary care. CVS launched I think they bought something, and then Amazon's got their thing going. And I think they made some progress with certain demographics. Yeah. I don't see it touching your population. No. Speak to that. I think that, that's, again, I think the healthcare industry gets more and more fragmented. And I think that makes it more and more challenging for those at the lower end of the spectrum. Mm-hmm. And so, locally, you can see in our market that you've got a lot more boutique clinics that have been set up that that cater to cash only sort of paying things that are going to you and I could afford to go there, but a great many people in the city couldn't go to get those services. Right. And so for those of us that in order for us, the way the healthcare system has worked is that you do rely on those people that can pay to help you fund the people who can't pay. Right. And so the more and more fragmented you get, where you're cherry picking off of those sort of things, it makes it a real challenging healthcare market. Definitely. So the balance is tricky though, because the questions kind of become, what is the proper healthcare? Yeah. And historically, the United States Preventive Service Task Force, USPSTF, they kind of set the standards on like what is appropriate primary care. Mm-hmm. And that's what I know as a resident and as an early clinician, that was kind of like my Bible. Yeah. I've subsequently understood that their goals are much more of a systems-based kind of thing. Like they want it good for the whole system. Mm-hmm. And it's not necessarily always the best individualized base. I remember it was like blasphemy the first time I heard anybody criticize, the USPSTF. I was like, well, that's not evidence-based. And it's true that they are evidence-based, but their objectives within that evidence aren't necessarily aligned with optimal health for individuals. It's aligned for optimal health for the system. Right. And that's a very different thing. Right. So when you have a group of folks that are willing to spend more to kind of get optimal, what they would consider optimal, or maybe cutting edge care, and you enter all of these like you described, kind of concierge or boutique stuff that takes dollars out of necessarily the system, but kind of provides that. So I don't know how you connect those without having separate systems. Yeah, I don't know if you can. I mean, I think it's the biggest challenge that we have. Yeah, I think you nailed it in terms of here in America. Obviously, it comes down to the individual. So and we're quite cognizant of that at Complete Health, that I can tell you that you should come to our clinic because it will help those that are, uninsured. You help us meet our mission.
But I also get that when it comes to me and my family, I want the best care.
Yeah.
For my, I'm no longer a socialist.
Right. Right.
I'm strictly a capitalist.
Yeah.
And I want what's best for me. And, and that's the tough thing. And so obviously the market or the healthcare industry is adapted to try and prop up those areas and still allow that independence. But it makes for a really messy, broken, fragmented system.
Right. So it seems like there needs to be some sort of a social safety net without stifling kind of the higher end of innovation.
Yeah.
That seems to be the optimal way, but there's a lot of opinions on that.
How you get to it.
And the social, or I should say the principle of justice, which is a legitimate concern, but it's it's interesting. And then it kind of gets into the whole pharmacy thing too. I wanted to ask you about that. So your pharmacy, I assume, falls under I forget the classification.
340B is what we are, yep.
And so that allows somebody who potentially is getting an expensive medication, but through your pharmacy for Medicaid, that actually helps augment costs for other folks too, right? Like that brings in...
Correct, yeah. So the 340B program is a special program that basically allows organizations that qualify for that, and we would be one, to buy meds really cheap. And so, so that we can then provide those basically at a much reduced cost. And so, so we can buy, so folks that may have a more expensive copay at Walmart, they may find that the copay is much lower when they come to see us, even if they're insured. And so, and then the caveat is that any money you make on that, I'm not buying boats with it. We're a nonprofit that gets reinvested into subsidizing,
and that's fantastic,
and making sure that those dental hygiene visits can still be $15.
It's kind of a symptom of a weird problem though, because it's like, okay, we'll pay you the list price even though you only got charged this amount for the med. It's just kind of this strange, it's like a reimbursement of a crazy system.
It's again a really complicated sort of way that, it's like, this is not as easy as it should be.
Right. And that's that system's sort of under fire too, or at least it has been. I've noticed several articles. Do you feel like that's pretty stable? Because my understanding is that's pretty important to organizations like yours.
Yeah, it's very important for us as an organization. And so, it's, I think that, it's definitely, I think there's been some abuse of it. And I think that's, obviously what they're looking at. The pharmaceutical companies are getting, harder edge with that. We're seeing the impact on that. We've seen some significant losses in our organization in terms of our ability to do that. And I think, the challenge with us as an organization, all community health centers, is we're kind of a small fish sometimes in a big pond. And so some of the things that are being, a huge thing like 340B that we fall under, it's clear that we are doing what needs to be done. We're meeting the intent of what that is supposed to be doing. We'll give you reduced drugs, and you guys, make sure that those that are, most in need are getting the access to the care. But when you're creating rules and laws and regulations, they sometimes are huge and unwieldy. And so, so we've seen some of those changes. Some of those we've seen I'd say probably. Last year, we saw a reduction in the revenue that we're making in our pharmacy enough that last year we had our first year that we've had a financial loss in many, many years. And so it's not like we make a lot of money. We're usually pretty much breaking even. But last year was a really particularly difficult year for us. Yeah.
Well, hopefully that reverses. You may be small, but I would say, if not mighty, quite important. Give me your your development as CEO. Was this something that you had ambitions for as a younger person? Was this something that you give me your background and story up to getting to the CEO position?
When I was in grade school, I decided that I really wanted to run a community health center. And my background, I was going to be a journalist. So my background, exactly. Yeah. So I went to school for, journalism. I worked in radio. So I, used to work with these microphones all the time. At some point, I couldn't believe they were paying me $10 an hour to do this. It was the most exciting thing I'd ever seen. And then I had a kid and realized I was going to try and see if I could figure out a way to make a little bit more money
to feed him,
feed the kid. And so I started working for a hospital in Tucson, Arizona, St. Mary's Hospital, which was just a hospital in the barrio, run by these nuns that kind of floated through the halls on their with their habits on and things like that. And so I started working in the marketing department, PR and marketing department, and really I just kind of fell in love with not the industry so much, but the people that are in healthcare. That they're just are some of the most compassionate people, and wanting to make a difference. And so that was kind of my start, my career in healthcare, and then got my master's in healthcare administration, and then eventually the job here appealed to me because I wanted to make a difference, and so and I always said it's a nice sized organization, so that it's like it's 100 people, you can know everybody.
Yes.
And what I love about where I work is that I told us yesterday when we were hiring the provider that we try to hire people that want to change the world, and are going to get frustrated when they can't.
Mission driven.
Yes, exactly. Yeah. And so, I want people that work there, and we are blessed to have just an amazing array of people that's what they want to do. It's like, why can't we do this? Why can't we do that? And sometimes my job as an administrator is to go, well, because we can't afford to do that, or that's outside of our scope, or whatever it is, and to try and constrain that. But it's just a great array of people that we have.
It is amazing, and I see this in your workforce, the folks that I interact with. They, many of them would be doing this outside of their job. This is stuff and when you have that kind of workforce, you can't buy that. That's, that's amazing.
Yeah.
What do you think the most underrated skill a CEO has?
Jeez.
That's a tough one.
That is a tough one. The most underrated skill, I think it's a sense of humor.
Yeah, that's good.
Yeah, I think, you have to be able to relate to everybody in a human way.
Yeah.
And so I think having a sense of humor is during tense situations and being able to say something lighthearted, I think, can often calm people down. And so I think a sense of humor is huge.
Absolutely. Well, your reputation, I know you might not appreciate this because we always try not to say good things when you're around, but your reputation is excellent in the community, especially as far as delivery of care, I think, to folks that are in the lower socioeconomic status. I'm curious as to your thoughts of how you relate to some of both the city and to Monument Health. I'm interested in your thoughts on, if you had thoughts I wish the city could do something like this, or I wish Monument, if you had any advice for Monument, what would your feelings be for both of those entities?
Well, I think that that we've always had, a really solid relationship. With Monument's been very supportive of us. When we built our building a number of years ago, Monument was said, hey, we understand the role that you play within the organization. That we'd rather have patients coming to you, than showing up in the emergency room and being hospitalized. And so this is an excellent way for us to support. So Monument's been very supportive with that. In the city, I think they recognize the role that we play. I think the challenge that we have, and you and I have talked in terms of just the homeless population that we have within the community. And I think sometimes as a community there is a desire sometimes to shuttle them to the side or out of sight, out of mind, or that we are providing them with too many services and therefore they're
you enablers.
Yeah, exactly. And honestly, I've never quite understood that because healthcare is one of those basics sort of that if you want people to be self-sufficient and move forward, healthcare is just, there's some basic stuff that you need to be able to provide.
Right.
Yeah. One of the things that, at Complete Health that we have a sliding scale, but we charge everybody that walks through our door, and the one exception is those that are homeless. And we don't charge them anything. Because we don't want that to be a barrier, that if you have a mental health issue, you should be able to talk to a professional about that.
It makes sense.
To get the medication that you need so that we can get that, because that is just the first things that you need to be able to do.
Yeah.
And it makes sense from a compassionate sort of thing, but I also go, it just makes sense from an economic standpoint.
For sure.
Yeah, that it's a pretty minimal cost in the grand scheme of things to keep people out of jail.
Yes.
To keep people out of, being, hospitalized. I don't know what a day is now at Monument, that if I'm spending the night there, but, we're talking thousands of dollars.
It's not cheap.
Plus the, ambulance services and the, all that sort of thing. And so it's a lot cheaper to come to a primary care clinic and get some of those basic sort of things and develop a relationship with that,
And the meds are heavily subsidized, as we talked about.
Yeah, exactly. Same thing. So that is, we always, we probably see, I think last year we probably saw about 700 homeless folks that came through our clinic.
Yeah, very meaningful.
Yeah, and in our total patient population, I think is roughly around 13,000 people that we saw last year.
Yeah.
So just to kind of put that in perspective.
Yes, that's a big. I mean, if you take our city's population, it's a
big chunk.
It's a big chunk
that we see that we take care of. So
and that's an interesting thing to bring up too for some of these high utilizers. I know you utilize community health workers as part of an outreach.
Yep.
So that's like a pretty. I would say proactive approach.
Yeah. Yeah. So these community health workers, we talk about people that want to save the world.
Yeah.
It's our community health workers. Yeah.
And they have skills with a Z.
Oh, yeah. Yeah. Just an amazing amount of skills. And what they are is, that they reach out and all the little things that fall through the cracks in a healthcare system that they, it's like, oh, we can get you signed up for these benefits here. We know that there's, this service over here, that you need a phone. We can,
Yes.
Yeah. As well as, being almost that life coach,
Yep.
I think in terms of going, it's like, you need to,
Well, for a lot of them, I think there's an element of peer support in that
totally.
too.
Yeah. And I do see that a lot in the healthcare system becomes that the coaching aspect of healthcare is I think kind of an underrated and unrecognized sort of aspect of what what you do as a provider is that you are that voice of
Yep. You mentioned Medicaid before, and I think a lot of people. I know I've been in probably 100 meetings where people are like, "Oh, Medicaid," But I think there's another side to that coin because when you look at community health workers, you look at the Medicaid health home. You look at, okay, it's not the best payer, but at least it's a payer.
Yep.
Give me a sense of how important Medicaid is, and maybe the strong argument for like why Medicaid's actually helpful, like the pluses.
Well, I think Medicaid is helpful. One, because it helps people, at their time of need, again, to keep them healthy, to get them access to care so they're not avoiding getting care. Us as an organization, the challenge is that we struggle with the fact that it hasn't risen at the rate that our costs have.
Right.
Our costs as an organization have skyrocketed post-pandemic. And it's pretty much staffing that we've had to increase the costs on that. And
there's some kind of inflationary thing happening. I don't know. You might have heard about it.
And as much as my staff are great and want to save the world, they still want to be able to get a paycheck.
Need groceries.
Yeah. I need to pay my nurses the same as
right.
any other nurse in town. So I think that it is a little bit like Medicaid is, kind of an incubator sort of thing, like a small business administration loan. It's like, how do you, it's like sometimes people just need a little extra step so that they can,
Tell me about the specifics as far as the way the community health workers and the Medicaid health home, because those are things that typically fall outside of the fee-for-service model.
Yeah.
And those are Medicaid reimbursable.
Yeah.
Tell me how you're trying to develop that. If you see that as like, okay, it's just a little extra and that's nice, or do you see that as something that might be a sustainable model if can be done in a certain way?
I don't think it's being reimbursed nearly to the point that it should be. Honestly, in terms of from my standpoint, again, going back to the way we're getting paid that extra for Medicaid Health Home. But there's a lot of rigmarole that you have to do to basically prove that you are doing everything that you need to do. And so most of what we get paid for, a good chunk of that is just for the administrative aspect of it.
Yeah, and isn't that the thing?
And
that seems to happen a lot with programs. Yeah. It's like a big chunk of it is proving, documenting, and then they come with stiff fines if you don't have that, right? So it's a scary thing to kind of get into.
So we are constantly always looking at CHW is the same thing, is that we get reimbursed for it, but not nearly what we're with, again, a part of the fragmented system that you always have to look at as an administrator is that, again, Medicaid is only a third of my population.
Yeah.
And so any service that we provide, we want to provide it to everybody.
Yep.
because the services are, that if you're uninsured, you probably need those services as well.
Yep.
And so who's going to pay for that? Well, I have to figure out how we're paying for that. There's a good aspect of our privately insured people that could use some of those same sort of services.
Absolutely. Yeah.
And each private insurance, they may cover it, they may not.
They probably won't.
They probably won't at this stage. Yeah. And so, it's like, okay, well, Medicaid's paying it, but it's only
they'll give you a
private.
form to fill out to inquire, though.
Yes.
Yeah.
So we're going to see how it works with Medicaid. We'll see if it saves.
And Medicare is kind of rolling through that too. I'm interested from a community standpoint too. I want to read you a quote here.
Okay.
And this is hot news around our area with Sanford Health. This is from Bill Gasson, the CEO, and he says, "We look forward to establishing a more permanent presence in the region and continuing to work with others to expand comprehensive healthcare services to patients in western South Dakota, including Rapid City and the surrounding area." So you doing what you do, I'm interested in your take on Sanford's arrival.
Nobody comes to knock on my door to say we'd like to take all of your uninsured patients. How can we help you? Yeah, take care of those a little bit better. And so, I think that I think this is always the challenge, that you can fragment the market even more in terms of, and that could be a good thing, it could be a bad thing. I think that there's clearly an access issue.
Yeah.
I'm not sure it's a lack of providers.
Right.
And that's it's like, it's if you drive around, dental is one of my biggest things that I look at in terms of, if you drive around town, there are a lot of dentists that we have in town.
Right.
There are dental clinics. Yeah. Is there one in this building? I'm not sure. Is there? Yeah. But we've got a lot of dental clinics, but there's a lot of, so I look at it the same way, that if you have a new dentist coming into town, does that increase the access to dental care? Only depends on which patients they're going to take.
Yeah.
With that, it's like, and so the devil's sometimes in the details in some of these things.
Yeah. I'll be interested to see how this plays out. But I did applaud the word comprehensive healthcare services with needs. It's a little strange that they started with a profitable orthopedic hospital.
Yeah,
but,
exactly.
But other than that piece, we'll give them the benefit of the doubt. But I was interested, and I think we're all interested to see how those things play out.
Yeah, totally.
But hopefully for the best. So when it comes to access, care, and the continuum, we're talking a lot right now about a fee-for-service kind of situation. There's another argument that we shouldn't be doing fee-for-service at all and should be all based on a value-based platform where a patient sort of goes under a certain umbrella and that umbrella gets an X amount of dollars, and then those dollars are based on what you can prove was accomplished. And I think we see that right now, with some of the managed care organization stuff. It's kind of this, anyone that has CMS. I wanted to get your take on that, and I'm interested in your take on that as a philosophy as it expands out. Like, could that be the model that brings access better for everyone? Yeah,
I do think that that we one of the joys of being a federally qualified health center is that we've been doing quality reporting. I think federally qualified health centers have some of the best data when it comes to just general primary care sort of measures because we are all required to provide it. So you can slice and dice that data a gazillion ways since the 70s, in terms of all that. So, and the great thing is that and I think it's fabulous that that we can tell you that if you're a diabetic, you're probably going to have a better A1C if you're in a community health center than you are in a private clinic. The numbers just bear that out, and particularly if you take out the social determinants of health aspect that are worse in a my patient population than they are for the patient population at Rapid City Medical Center.
Which affects outcomes negatively typically.
Exactly, yeah.
Right.
And so you pull it out. We know that our quality measures are great.
Yeah.
And so, the challenge, obviously, it's much like the billing aspect of it is, how are you going to define these values, and can we all agree on them?
No.
And I have probably, 16, 17 providers in my organization, and getting them all to agree on, what's the most important aspect of anything or what value is.
Sometimes medical providers have some opinions.
And so, I think that's, it's like, and what scares me is that, almost the primary care always seems to get the short end of the stick, I think, when it comes to the value aspect of things.
Well, because it's important, but not emergency,
yes,
right? Yeah,
exactly.
So it's easy to kind of
So it's like, you got to define for me what you consider to be value.
Right.
And I think that almost gets back to what you were saying in terms of value to the community as a whole, or value to the individual.
Yes.
And so that's when I was doing my master's, I did a lot of study on the Cuban healthcare system.
Tell me about that.
Which I thought was just fascinating, because their health outcomes in Cuba were, better than America when it came to, unless you had stage 4 cancer. But they just had an interesting model. I don't know if they still have it, but basically where you could go to medical school for free, the government would pay for it, and then it's almost like the military, where you get assigned like a neighborhood, where this is you have this quadrant that you are in charge of the healthcare and taking care of all of the healthcare.
Ultimate value-based assignment. Yeah.
You will be housed here in your clinic, and you will take care of this neighborhood.
Some maybe human rights issues, but I bet the outcomes for there are
good.
For
sure, yeah. So those providers, it's like they're making sure that that group is taken care of, and and obviously real primary care sort of basic stuff. Low cost sort of things.
Yeah.
But they were incentivized, obviously, in terms of, I want to make sure your diabetes is taken care of, and all that sort of thing. Because one, if you have some really severe complications, there are a whole lot of specialists that we can send you to.
Right.
Yeah, and so we're incentivized, and so, but that's the question in terms of how do you, what's the value?
And one big piece of this that I've thought of a lot is, I think quality can only be as high as the tools you use. And you want to talk about fragmentation, you talk about our EHRs, and you talk about the laws and regulations regarding our own personal health information.
Yeah.
I get frustrated with this all the time. And I think our legal and compliance, they get frustrated because they understand the stiff penalties that could be bestowed upon our organization. So they're like, no, you have to do all this stuff. And to us, it's like, well, this doesn't make any sense, but okay, we have to do it. How does it work in your umbrella when you deal with your EHR and communicating with subspecialists, and what would you like it to be? How do we make it better?
Oh God. I think that what I've been struck in my 15 years at Complete Health is how our IT sort of side of things, the costs for that have just blossomed.
That's another thing people don't realize that.
Yeah, that you've got to be able to pay for it. Cybersecurity. And protecting all this is, in United Healthcare being, a great example of, with the Change Healthcare sort of, blackmail that they had a year ago or whatever that was.
Yeah. Tell people about that, because that affected.
Yeah. Well, so part of United Healthcare is Change Healthcare. I forget what they're called exactly, but, it's like a third of all health sort of stuff goes through this transactional sort of, hub. And, they got hacked.
Right.
And so, so for us, it impacted us. There's aspects of our care that kind of go through that. So it's like,
us as well. Yep.
And, it kind of grinds a little bit of the healthcare things to a halt. But, the cost of protecting yourself against that sort of thing. I cannot imagine how much United Healthcare has to pay for their cybersecurity insurance plans.
Yeah, and that all gets passed on to customers.
Right, and it drives up the costs. And so, it's but it's key, obviously. I don't think it's unique, obviously, to our market. I think that, obviously that cybersecurity thing is, kind of lost my train there. But,
I think one thing, a lot of people would be very surprised to know, and this isn't always a precise number, but what percentage of revenue from third-party payers is taken away by your tools, your EHR, for example. A lot of small clinics, you're getting pretty close to 10% of billables being paid.
Yep.
That's a big chunk.
Yep. Yeah.
So that's just to run your tools, and that's not on top of anything else that you may have protecting you from cybersecurity, anything of that nature.
Yeah, well, I think you can also, in terms of, obviously there's a lot of value in a lot of the, that you're able to really, I think, get more into, quality.
Yes.
And really, dissect, truly, are we improving things or what sort of things? So I think, there's a benefit to it all, being able to take a look at all that data, if you will. But there's a lot of data.
There is. And again, it's tied up in regulations. I know Google tried to come up with a unifier years ago. Microsoft tried to come up with a unifier where people put in all their data. They were going to create, all of it. Even back then, they were talking about machine learning. And I remember seeing that as a med student, which sadly was a long time ago.
Yeah.
And I signed up for it because, this will be cool. And it died, because it didn't have the utilization. I'm hopeful now. Things seem to be getting maybe moving towards the right way with IT. Maybe we don't have to spend 10% of revenue on maintaining an EHR that has access to everything and can properly go through the billing pieces.
Yeah, and there's certainly, there's obviously been some consolidations in the markets that there are, fewer and fewer products out there. I mean, it was pretty Wild West there for a number of years that you had, gazillion different little products that were out there that,
I think there was a lot of grants around that time trying to get people to develop stuff. So
I think one of the government's big mistakes is when they, did meaningful use sort of things to try to do all that. Yeah. I wish they had said, we're only going to give you this money if you select, X product. Yeah. To see if they couldn't consolidate the market onto one. Yeah, but I presume that probably that was maybe wishful thinking on my part. But
yeah, that was a little before my time, but I've read the history of that, and that was quite a process back then. I before we end, I did want to talk to you a little bit about big picture and population health. Yep. And I'm curious from your perspective in our community and the scope of folks you care for, what are the biggest health detriments out there? What can we do as a city? What can we do as citizens from a population health standpoint?
Well, I think mental health. You can't, start. That's where it kind of starts. And it's amazing to me, particularly when it comes to pediatric mental health, how that's, just, kind of jumped up. Yeah. Really post-pandemic especially. So we see that a lot at our clinic. And it's sad, it's just, it's always trying to dissect in terms of, what exactly has happened to us as a people that, that our mental health is in such, difficult, reaching out for connections, reaching out for, needing more than probably we needed in the past. And so, I particularly for when it comes to the pediatric, it's like, this is the next generation that, we want to make sure that they've got access to, we run our IRIS clinic, our LGBTQ clinic that we've run for a number of years. And really that's, from a primary care medical standpoint, there's nothing different about somebody who is, LGBTQ. Right. They have the same immunization needs and the same, cardiovascular needs and all that sort of thing. The thing that why we did it is, purely because of mental health, is to make sure that, these kids felt like they had a safe place that would accept them, that would allow them to talk about these issues that they may be having. And it is, I think that we as a community need to make sure that we are, doing that and making sure that we are addressing folks' mental health stuff. In terms of, dealing with your work with homeless populations and with, substance use, that goes hand in hand with a lot of mental health sort of things. And to be dismissive of that, not recognize that, or to be shifting those individuals, it's just, there's a severe mental health crisis that we need to be able to address.
Yes. I often feel like I spoke with Amy Iverson here, and she's obviously very in that space. Yep. And I'm just always, I guess I'm disappointed that we don't have a better way to coordinate among all of our groups. It always seems like so many of us have to start over again when we bring our piece of the puzzle. And I don't know how that can get better. I think better integration, like we talked about before.
Yeah. I think, we've got to get better with the tools, obviously, in terms of, we've got to, and the challenge, and that's why I say when you have another Sanford moving in and, splitting up the market, the more fragmented it becomes even more challenging to do that. But, and that's why I always say the model should be just like us, that you've got a one-stop shop that right. When my medical provider sees that the homeless person has some sort of a mental health issue, we can walk them down the hall to the counselor and the psychiatric nurse practitioner to get them
Send them home with a community health worker.
And let's get them on the med that they need. And,
make sure they filled it.
Exactly.
So for 2025, what are you looking at? What's your goals? What's your ambitions? What are you trying to go for?
Honestly, last year, it's a bit of trying to figure out exactly what's going to happen. And last year, financially, is that we're struggling to just figure out how we're going to continue to meet our mission. And I don't see that is going to change in 2025. That I'm not seeing that there's going to be a whole lot more money coming my way. And so, one, how can we work smarter and to more efficiently? And so, we're putting in a new EMR this year at our clinic.
Oh, what are you getting?
Athena. I'm going to.
I like Athena.
Yep. So, so that'll be an upgrade for us, and so that, that'll give us some efficiencies and all that sort of thing. So, trying to keep up with the times with that.
Everyone's gonna love it when they switch over.
So our current system isn't that great. So I give the honeymoon period with the providers 3 months, 4 months before they start coming to my door complaining about this.
Well, it'll be a disaster at first, and then it'll get better. I've been through 3 EMR changes, and that's usually the way it goes.
So.
Is a mourning period,
So I don't think we'll have a mourning period. We're gonna have a bonfire for our existing EMR, I think.
So new EHR, kind of see the landscape. What's your best hope or your best ambitions for the way healthcare looks from the federal level, the policies that come through? What's your hope?
Well, my hope would be that if Robert F. Kennedy gets the nod, if he was to pass, that. I may disagree in terms of some of his stances when it comes to vaccines, in terms of all that. But my hope would be that there would be a focus on primary care. That, it's what can we do?
I think there would be.
And I think there's some benefit to that in terms of So and obviously there's the funding shift. Is there things like that allow you to do more in a primary care setting? And so I think that would be promising from my standpoint. That if that $13,000 we are spending on Americans per year, if we could jump up that $600 that we're spending on primary care to to $1,000 per American on primary care. I would go, does that make sense that you're going to be able to reduce the overall cost over time of that full $13,000? And to me, it makes sense. Some of that preventative sort of things and making that much more accessible. The challenge I think that we'll have is that that we rely on that. Medicaid is a huge payer source for us. And so from the state level, in terms of, obviously we passed a work requirement sort of thing.
Oh, we should talk about that. I'm interested in your thoughts on that.
Well, I think, from a philosophical standpoint, I go, that I go that, from a philosophical standpoint, I go, if somebody's able to work and they're fully functioning and all of that sort of thing, then, I think that they should work. Whether they're on Medicaid or not. I think that's but I think the challenge is that it is going to be and we've seen this in the states that have done it. It becomes an onerous sort of thing to how are you going to prove that, and how are you going to continue to check all the boxes to show that I'm and we know. Anecdotally from working with these individuals, the vast majority of them work, or that they would qualify for an exemption to it because of whatever reason. And so now it's one of those we're going to have to check a lot of boxes. It's just like the insurance thing, in making sure that it's now denied because they haven't completed all of their work requirements sort of things.
So good in philosophy, but maybe more trouble than it's worth.
My concern is, exactly. The amount of money that you would actually have to spend, and I don't think we're going to increase the cost that we are going to spend to
You mean you don't want another person to track things and check boxes?
Exactly. So that's my concern. Is that,
grow your administrative staff to 9 for that.
It seems to be a solution that's in search of a problem.
Yes,
and it is going to have its own issues that is going to trickle down. So
that was my feeling with it as well. I understood why the population voted for it.
Totally, I get it.
But it's and then again we come down to the same point. If they don't have Medicaid, they're still going to get services. It just becomes more expensive services because they didn't get what they needed. And it's an access issue to the stuff that is preventative. So,
and that if you have, one of the things about access, it's not just getting the services, is that if you have that, if you know that you don't have to fight through all the red tape to get services, you're more likely to access that services,
Right.
and your health outcomes are better.
That's a barrier, right?
Yeah, it's a huge barrier.
Yeah,
and so just going through all that headache of it, it's just it takes that out, and you're going to have better outcomes, better compliance.
And one of the things again with the community health worker, they can bring access to the patient and connect them to a provider.
Yep.
And so that's like the ultimate. Do you feel like telehealth plays a significant role in your organization now, and how would you see it in the future?
Yeah, it doesn't really play a huge role in ours. The mental health side of things,
Anything.
a little bit more in our organization, but from a medical standpoint, it's not a lot that we do. We do have some of that, but and I do think that that's more and more. I think that we would have to. I think it can play a huge role, particularly when it comes to just maintaining those connections with that patient. So
let me ask you a question. I wanted to end on this. I know. I think I already know the answer to this, but given the fact that you already have a large sunk cost, kind of with everything you do, do you ever think about augmenting your revenue by creating services that are maybe on the more profitable side to sort of keep the other things funded? I know a lot of people look at that, but then they're like, well, this isn't part of the mission, and this is probably more of your board that kind of thinks about this thing. But I'm curious.
Yeah, well, we that's one of the things that we did with our pharmacy, was to try and figure out how we could use our pharmacy to, that we could make money off of that. So one of the things that, when you do get a grant from the federal government, they have restrictions in terms of what you can do with that. Because you can't unfairly compete. It's like, we're giving you kind of a heads up in this area. And so, it's like, okay, you can't unfairly compete in that area.
Well, I mean, for example, I know there's places that do like executive physicals and stuff that charge a lot out of pocket, and cosmetic stuff. And I don't know.
It would be outside of our scope and really outside of our mission.
Yeah,
Terms of,
then you would lose some of the employee, like, what are we doing over here? Yeah, Tim, your organization is extremely important to our community. I'm super impressed with it, and I'm so glad you're here and doing what you do, and I appreciate you talking.
Well, thank you for your support. I appreciate all that you do. We're big fans of you as well.